your host, Dr. Mike Matthews.
Hey everybody, welcome to episode 25 of the Athletic Potential Podcast. Excited to have you back, excited to be here. As a general review, we usually, each episode encompasses two main things. The first being a case. It's typically the last patient I treated prior to the recording of this episode. And then the second thing we do is take questions from our audience and get them answers as best we can. So let's jump right in. Episode 25. So we more recently have been treating a patient who's 22-year-old female volleyball player. She's an outside hitter, fairly tall, and she came into us complaining of shoulder pain. And when we initially did an examination with her, she had full mobility. She could move in every direction. She had pain predominantly with full external rotation, the lay back all the way behind. And she had pain anytime she tried to go and hit a ball overhead hard. Even soft hitting was starting to become a little bit more painful, but it was mainly when she was trying to really put some force into the volleyball that she noticed the pain. Now, in her case, she's been playing for quite some time. She has a multi-sport background. She's never had pain like this in the past, and she had no eliciting onset or anything that would really indicate why this started. She didn't start playing volleyball more. She didn't have more hitting. She didn't have an injury. She didn't have a major growth spurt. She predominantly talked about the fact that she had noticed a couple different things. One, she'd been working and getting a lot stronger, and she had just more recently done months, and I think she said anywhere around a 3 to 4 months weight training program, and not with us here at Athletic Potential, but an online version. And she'd been fairly consistent with that and seen some pretty good improvements in her strength. And she also reported that she felt maybe she experienced a little bit more stiffness generally throughout the upper body, thoracic spine, and to be honest, her hips and lower body as well. But she did also notice an increase in her ability to hit the ball with higher velocities. And so she was pretty excited about the gains she had made with the strength conditioning program. And but then had more recently started having some of that shoulder pain. And so we were able to see her and start looking into some of the things that we were seeing. And she definitely tested positive and had pain with forced external rotation, so passive. So she was up, arm up at 90 degrees, and if we pushed her arm further into external rotation, that lay back position, she had increased pain, and the pain was predominantly more on the top and the front of the shoulder. And this was reproduced in standing as well as in laying on her back. And so it wasn't just in one position, it was kind of in any position that we put increased external rotation. She had increases in pain. And then when we did all of our strength testing, she didn't test positive for anything. She had some minor soreness, or she said she could kind of feel it with internal rotation. So the test for that, pretty straightforward. If you're looking to see if you have an issue with your internal rotators, you take your hand, you put it directly over your belly button, keep your elbow out to the side, and you push as hard as you can into your belly. And if you experience pain specifically more on the front aspect of the shoulder, then you may more than likely have something wrong with the internal rotators, specifically the subscapularis in the shoulder. And we did that test with her, and she reported some pain, but to be honest, it was really minimal. We tested, there's a few additional tests for that muscle, and none of them were positive. They aren't the best tests in the world, but so we kind of went off with the fact that, okay, maybe she's got some internal rotator problems. And so now we're talking about muscles that do internal rotation of the shoulder. And we were able to identify that she did not have any pain in the muscle of the rotator cuff that does the internal rotation, the subscapularis, but she did have pain more towards what's called the groove, the intertrabecular groove. It's where your biceps tendon lives. A lot of people like to say that biceps tendinopathy when they have this pain that's kind of right on the inside part of their shoulder. And she had pain in that location. However, when we tested biceps and everything, it was irritable, but to be honest, it really was minimal in regards to the pain she was experiencing. We did some labrum tests, which is arm up over the top and having her pull and push, and it created pain, but not in the same way that we expect where the labrum would. So we kind of said, this could be a labrum problem, but we didn't think it was. She had been informally seen by another clinician, and that clinician had given her the diagnosis of a biceps tendinopathy. And I just didn't see it. I didn't see it in an exam. Maybe it was more inflamed or irritable when he or she saw her. But I didn't see anything in the biceps. I felt like the bicep was okay. So we started testing more specifically in different muscles. And what we found was internal rotation was like pushing and pulling towards her was definitely the pain-provoking activity. And so we started thinking it was more of a muscle problem. And when we really got down deep on it, we figured out that she had more of pain associated with where her lat attaches up into the front side of her shoulder than anything else. And then when we tested her lat in different positions, it tested positive. So we were pretty sure she had some a lat strain, specifically where the tendon attaches to the bone in the shoulder. And this is a little bit counterintuitive for a lot of people. The people think lat, they think that big back muscle, and they always point to like underneath their shoulder blade, up into here, or up underneath their shoulder blade behind them on their back, and that's typically where a lot of people are like, oh, my lat's over here. This is where I feel it. And that's where lat strains happen, and they can happen there. However, where that lat attaches is actually more towards the front aspect of the shoulder. It goes underneath and kind of dives deep, and then eventually attaches to the bone of the humerus or the muscle or the bone that's on the shoulder, and that's where we normally see the pain coming from the lat. And so we tested there. That was definitely positive. Now, in her case, she hadn't stopped hitting, and she was kind of at an ideal time to stop. And so we instructed her to stop hitting and stop practicing volleyball. She was allowed to do like setting, and she was allowed to bump and do those other motions as long as they weren't painful, but she wasn't allowed to hit. We even kind of encouraged her to maybe take a few weeks off of volleyball, to not even show up to the court. She had been going straight for years and years and years. I mean, she's 22, she's a collegiate level athlete. And so she just really hadn't stopped. And we were in an off season. She wasn't in her school. She was home at that point. And so realistically, we said, look, now's a great time for you to figure this out, but also maybe just for a minute, take a step away from volleyball. I mean, you don't have to like not watch it or anything like that. But the idea would be maybe don't go to the court every day. Maybe, take a little bit of breather from it, because we did see some, and we see it in different athletes, but a lot of collegiate athletes, sometimes they just are, it's a long grinding schedule, depending on the sport. And to be honest, on any sport in collegiate athletics, typically is a grind. And we just saw some of the effects of that in general health with her. She had low energy levels. Like she said, she had made some pretty substantial gains in strength, but to be honest, her energy, her power, her ability to move quickly, just wasn't really where we wanted. And it was almost like a fatigue thing. So we kind of gave her, I told her she had 10 days to just do what she wanted. In regards to, the sport, told her she could not do anything with the sport. She could do whatever, just essentially just take time for herself, relax, eat good food, home cooked meals, those type of things, sleep. She wasn't getting enough sleep, so we encouraged her to sleep a lot, and encouraged her just to do those things. And to be honest, we saw pain levels drop. And granted, she wasn't hitting, which is her main pain-provoking activity, but general level pains, we were able to test the shoulder within about a week of that time period, where she just was pretty much not doing anything sport related, and her general pain levels in the shoulder were substantially less, and that was with her doing exercise. So I think she just needed to recover a little bit, and that helped a lot. So something to be said about that. And we've talked about in past podcast episodes about making sure in recovery strategies to take care of the low-hanging fruit, to become hydrated, to sleep enough, to eat good food, those type of things. And so anyway, we were able to put her on what we called the lat loading protocol or progression. And it had 3 phases. The first phase was, look, we just want to put stress through it. So there's 4 exercises. I'm going to have to think about them here. So the first exercise was a standard lat pull down, a seated lat pull down using a cable column. The idea here is we just wanted to pull the bar to her chest, but to demonstrate good scapular mobility and scapular control, which she definitely needs some help with, and improved pretty dramatically quickly. The second thing was assisted pull-up hold at the top position. So think bar, same thing at the bottom part of the lat pull down, but now you're holding onto a bar hanging, and the bar's up to your chest. She wasn't traditionally very strong in pull-ups. She's fairly tall, and it's just not something that she really trained a lot. And so the isometric holds with the assistance of bands really kind of worked her. And the good news is that this is a we see a lot of lat activation here, and she had no pain here. So this is good news. From there, we had her do what we called ring or suspension trainer Supermans or Superwomans, and it's where you stand and it's essentially a rollout using the TRX or suspension trainers. And the key here is that they're in a false grip, so their hands aren't in neutral like this. They're definitely not extended. For those that can't see and they're listening to the podcast, I'm extending my wrist, and that's not what we wanted her not to do. We wanted her to flex her wrist, pulling it towards her fingers towards her forearm. I call it a false grip. I don't know where I got it from. It's probably not correct, but I call it a false grip. You're going to grip this way. And the idea is if she holds with wrist flexion and then goes out into that extended position, doing the suspended trainer Superman, we seem to see a little bit more activation through the core and the lat, and that seemed to be better for her. So we had her do those. And then we had her do a very basic plank maneuver, but it was unstable. So in her case, she had to be on a Bosu ball, and what I wanted to do is like pitch her weight forward and push herself. I don't know how to describe this very well. There's videos on the YouTube. I think we call it jigsaws is the more advanced way we look at this. But I think the entire protocol is on the website, is on our YouTube channel. But we had her do a slight regression on that, trying to just basically get her core involved in stabilizing. And what we found, and this is not specific to her, but more specific to our athletes that deal with lat injuries, which is any of our overhead throwers, we always kind of worry about it, is that we have seen substantial improvements when we don't train the lat in isolation. And it'll sound a bit basic when I say it this way, but the idea is that we've been really limiting our ability to just essentially sit and do a lat pull down, because what I really want to see is the core engaged. I want to see obliques, abs, transverse abdominis, rector spinae, all those muscles that incorporate pelvic and lumbar spine control to be contracted and on and stabilizing, because that's the other insertion point of the lat, is down in the thoracolumbar fascia. And I feel like if we don't tense that thoracolumbar fascia through core control with core muscular activation, then we lose a lot of the ability to affect the tendon at the shoulder level with the lat. And so it's something that we've been incorporating more and more, is essentially as we increase demands on the lat, and this is exactly what we did with our player here, the volleyball player, is we said, look, we're going to start here, and if there's no pain, we're going to slowly progress you into movements where we're asking you to go into further external rotation, but extension, and having to really incorporate more core activation. And let's see how well your shoulder and your lat tendon tolerate this. And we were able to progress her from a fairly simple protocol to some fairly substantial and advanced level exercises that required substantial core control. And we were able to see almost no negative effects to the lat. Excuse me. And what we noticed is that we were able to allow her to start getting to external rotation and start hitting volleyball lightly, and her pain was gone after these progressions. Now, it took a couple of weeks. Now, remember, we're talking about her taking 10 to 14 days off. She ended up taking around 14 days staying away from the sport entirely, getting sleep, food, those type of things during the exact same time period. We went through 2 phases of the lat loading progression or protocol, and at that point we allowed her to start hitting, mainly just to see if it was better. Now, the other couple things that we did is that we did dry needling on the tendon at that area. It requires a very specific position, and then you got to be pretty cautious about what's around there, because there's some vascular structures as well as some neural structures that we have to avoid. But we were able to get right on that spot where she was feeling it. So I feel like the dry needling helped dramatically. And in addition to dry needling and loading at the same time and not hitting, I think we saw the tendon change the way we wanted it to. She was able to start hitting about 14 days with no pain at about 50% of her normal load. This was just hitting straight ahead. I think jump serve type stuff, but really minimal. And then we were able to load her pretty quickly after that. Another 4 to 6 weeks. She was in off season, so we were able to do it. 4 to 6 weeks, strengthening, lat loading protocols, and back into hitting. And the last time we talked to her, because she's no longer around, she's feeling awesome. She's 100% back in her sport. She has no issues at this point. And we should see her getting a lot of substantial playing time in volleyball. So fun case to see. Lat injuries are fairly common in throwers. They're fairly they become injury prone in different positions, specifically the arm up overhead. We see it in other athletes. CrossFit athletes get lat strains as well. And that one's mainly because of overload and those type of things. And overload including all sports, not just CrossFitters. But the lats can become a pretty tough structure. And if they're strained, they become very difficult to train, specifically in baseball throwers and softball throwers and javelin and volleyballers, because it's a muscle that does contribute quite a bit. So if you've ever experienced a lat strain, they're no fun. But if you are currently have a lat strain, there seems to be a nice common progression that seems to work. But we've got to make sure the tendon's in the right place for it to heal, and it takes some I should just say it takes a plan, it takes organization, and it seems to work. We've been able to get a lot of our players back fairly quickly and without major substantial problems and those things. So that does it for our case, and so let's jump right into our questions. And so as a reminder, if you have questions for us, just go to the website, www.athletic-potential.com/podcast. There's a button on there to hit that'll say ask Mike a question or ask the podcast a question. Click that, submit your information. It does ask if you want to submit an email. You don't have to, but you can put your email in there if you'd like to. Ask your question and we'll answer any and all questions we get. So let's jump right into our first question. And this one is from Dylan. He says, do you recommend different arm care programs based on position played? I'm assuming that like positions in baseball, softball, like first base, second base, stuff like that, pitcher, that kind of thing. This could be in regards to any throwing sport. Oh, okay. So it could be javelin, outside hitter. We just talked about that. So any throwing sport, any position. Okay. And if so, what are your recommendations, or at least your basic thought processes when prescribing these exercises? It is a big question, Dylan. I'm going to try to answer it as best I can with those general principles. How about that? Because you basically ask a question that goes over the entirety of like any overhead sport, that's a tough question to answer, because swimming is an overhead sport, and they do specifically more specific exercises that can deviate substantially from baseball and softball. But I think that's what you're getting at, is like, okay, well, what do you look for, or what is it about the sport that then prescribes certain exercises? So let me tell you this. The first thing you need to do when we're talking about arm care, and we're going to talk about arm care, it could be any exercise or it doesn't have to be arm. We call it arm in the baseball and softball world, and a lot of times I look at it and go, arm care, like it's all shoulder exercises. We should call it shoulder care. And then we look at it and go, well, what about the forearm and the elbow? And so elbow, shoulder, forearm care. It's brutal. That's why we call it arm care. But realistically, I think we need a kind of a name change, a little brand shift away from arm care and just call it body care in a lot of ways. But in a whole nother tangent here. But Dylan, in response to your question, so first thing I like to do in regards to these athletes that have these more repetitive, high velocity, high speed, high intensity type motions that are specifically more overhead, swimmers would count here. And I look at it and go, okay, great. What muscles are predominantly being used, and in what way? So let's take a baseball player, for example. We know that the rotator cuff is heavily involved in the baseball throw. However, it's heavily involved at different phases. One of the main roles of the rotator cuff, think all the muscles in the backside of your shoulder, is after the ball is thrown, we'll say pitcher's case, so after the pitch is thrown, the ball is out of the hand, the arm is accelerating and has accelerated up to that point where the ball leaves the hand. At that point, it needs to decelerate because the arm is literally trying to rip off and go to home plate. Because all the force went that direction, but it went into the ball. But we don't want the arm to go to the home plate as well, so we don't want it to rip off. Well, the whole job of the rotator cuff is just to hold the ball in the middle of the socket. And so we know the rotator cuff works in a lot of different ways, and one of those ways it does work is to create, to resist traction, to resist forces pulling apart, right? And so it basically just holds on tight as the ball is let go of the hand, out of the hand, and that's an eccentric load, a lengthening contraction that we see. So we look at it and go, okay, rotator cuff in the shoulder for baseball players, volleyball players, softballers, right? I don't think we include swimmers here as much. Okay, they have an eccentric load to the rotator cuff. And then we know based on that there's certain things that happen with eccentrics, okay? And this may be getting a little layered, but we'll stay out of the layers here. So muscles work rotator cuff. specifically on the eccentric phase. I don't even know if you need to know the eccentric phase if you're talking about basics here, but essentially just know rotator cuffs being worked because the shoulder's trying to rip off and go to home plate. Now, in regards to the arm, let's talk about, bicep, tricep. They're helping, but if you look at it, they're not doing as much as we think. They are contributing. So I definitely don't think our athletes, our softball, baseballers, volleyballers, javelin throwers, they absolutely work biceps and triceps, but in a very specific manner and usually never in isolation unless they're coming back from an injury. But what we found is I look at that and go, yeah, you know what? Most of our work, as long as they're doing basic strength training exercises, rows, push-ups, or pressing variations, those type of things, I'm not really worrying about their biceps and triceps. Okay, I can tell you that if we start at the shoulder and we look at the rotator cuff, right, and we think delts and those type of things. Well, the deltoids are doing a little bit, and they're all also assisting the rotator cuff. However, I also think they get most of their work in the strength conditioning program, the pressing variations more specifically. So I don't worry about those in regards to arm care or the shoulder care that we're talking about. What I like to look at then is like, okay, well, we looked at the shoulder, scapula. Scapula is doing a lot here. So as the arm goes into different positions to go lay back, to cocking phase, to rotation, to lay back, and then acceleration going forward, the shoulder blade is essentially just trying to stay in the right position to allow for the rotator cuff to do its job and to create the maximum amount of speed or rotational speed to allow for the ball to be thrown as hard as possible or effectively as possible. And so we look a lot at like the shoulder stabilizers, scapular stabilizers, and I like to prescribe exercises for those, specifically the ones that don't typically get used, again, in the strength conditioning programs. Rows, any rowing variation is going to get a lot of these muscles, but I like a serratus slides, driving the arm with the wall for the serratus anterior, which is not typically used in a lot of our movements, more targeted. And so we look at scapula, we look at shoulder. Now I'm going to go down the arm. We're talking bis and tris, we're okay with that. Now we're going to go down to the elbow. Now we're going to talk about forearm musculature. This is extremely important, specifically more in baseball players, definitely softball players. Even in softball windmill pitch, even has some significant forearm stresses that need to be addressed. But what I've found is we have to address these muscles, specifically these muscles on the inside of the forearm, right? The bones here, those that can't see it, bone on the inside of your arm, and the muscle mass that's above it. Flexor pronator mass is what it's called, and we definitely want to do exercises for that because that is the predominant stabilizers of the inside of the elbow. It's essentially the muscles allow for that ligament, that Tommy John ligament, not to be injured on every throw. Okay, they did that study where they looked at the amount of force it takes to essentially tear the Tommy John ligament, and the forces of each throw, at least in the major league and minor league level, I think is where the data came from, exceeded the amount that ligament can handle. So why doesn't it blow up with every pitch? Well, that's because you have muscles that are helping here, and so they're extremely important. And so we definitely do forearm care or whatever we want to call it with our athletes, so because those muscles are heavily worked, right? So again, Dylan, to bring you back, I kind of went on a tangent with baseball, but just try to give you an example. Whatever sport we're talking about here, look at what muscles are predominantly being used, specifically in high volumes and high intensities, okay? And more, I'll be honest, if you look at them, they're not typically these big muscle groups, right? We didn't talk about lat. Well, we talked about lat in our example, or in our case, but we didn't talk about lat here. We're not doing lat-specific exercises here because they're being addressed in the strength conditioning program. So if you're not doing a strength conditioning program, that's arm care, shoulder care, body care, right? You have to go through some of these strength movements in order to be able to get the other muscle groups. So I look at that, I didn't introduce lat, and the only time we introduce lat is mainly because we see lat deficits or pain. So I didn't mention lat in regards to arm care, but if you look at a lot of these muscles, they're smaller. They're the smaller muscle groups that are typically overtaken by the big movers and the stabilizers in a lot of ways. We do a lot of hip care with our baseball players and softball players and volleyball players, especially because they jump so much, right? There's a lot of hip care. I was introduced to this concept of the hip rotator cuff, and we keep talking about the shoulder and how it has a rotator cuff, and that's well known and kind of known across, general knowledge. But if you look at the structure of the hip and the muscles that are there, it has its own rotator cuff. Now, it doesn't have to work as hard because the ball, it's a ball and socket, and the ball is actually encased in a bone, essentially, as opposed to the shoulder where it's just more sitting up against the bone. But the hip has a rotator cuff, and we train the rotator cuff of the hip. We kind of have to. Otherwise, we can see some problems there. So, Dylan, again, come back. Let me try and make it a little bit more simple And that is, whatever sport we're talking about, figure out what muscles are predominantly being used in those specific motions, right? So if swimming, you look at which stroke are we talking about? Backstroke's going to be different than freestyle. It's going to be different than butterfly, right? If we're talking about golf, there's golf-specific exercises because of that swing. It's a very similar, if not same swing, with different intensities and those type of things. Obviously, putting is different too. So you got to look at it that way. And then what we do is we take the idea of, we know which muscles are being used, we know which joints predominantly are being stressed, and we look at those muscles that are predominantly being used and that have a tendency to maybe be overworked or essentially become weak because of overuse or overwork over time, and we then design exercises specifically for those muscle groups. And that's where our came from. Is they did a study in the rotator cuff, and they put EMG pads or even needles in some of them and tested which muscle and what movements were the best to get the most electrical activity, and that's where your throwers 10 exercises came from. That's where your band and J-band routines came from, is all from that kind of similar research. And so that's essentially what we're doing when we talk about arm care and those type of things, more specifically the muscles. So Dylan, I don't know if that answers your question specifically, but now you kind of know the basic thought processes we go through. So if I have somebody comes in who's a cricket player, I have never treated a cricket player, and I would then probably go through that same process. Okay, are you a cricket bowler? You know what I mean? Let's do it. Let's figure out what those motions are. What predominantly is going to do those motions? What muscle, or muscles are incorporated through there, and then how much stress do they get? And then we go from there. So, Dylan, I hope that answers your question. It's a great question, and if you have more specifics, sometimes it gets a little bit easier if we have more specifics to go into it. So feel free to reach back out to us. There's an email on the website, or even just call us. We'd be happy to go through it that way. Let's see here. Next question comes from Bo. What have you discovered most recently that has helped your athletes the most at athletic potential? This is a great question. What have I discovered more recently, or most recently, so like just now, that has helped more of our players? Something, we'll say it's something new, right? So something that I've just been incorporating more and more. I tell you what, Bo, one of the things that we're doing right now, more than we've ever done before, we've been heavily looking at EMG activation or activity in muscles that we're trying to work, specifically, to Dylan's credit, to like arm care. Baseball players go out and do a tremendous amount of shoulder exercises, yet somehow still test weak all the time. And it's kind of one of those things I look at and go, there's no way they're actually weak. But maybe they are because they're doing too much. So what we did is we wanted to restrict the amount of exercises they're getting, but maximize the quality of the exercises they're getting. And we decided to do that through an EMG machine. And I can tell you right now that has significantly changed the way I practice. I could say that yesterday I saw every patient but one yesterday had some form of EMG exercise or test or something done. So I'd say EMG right now. EMG. It's a great system. I love the idea. I've got guys working. We just get the most out of every exercise, get the most out of every movement. Teaches us a lot, gives us motivation, gives us another test, something to look at. We look at deficits side to side. It's not the most accurate thing, I don't think, but we definitely notice that it gives us something to go off of. So if we see trends that aren't looking very good, then the EMG allows us to kind of progress. We've got a soccer player right now who had an ACL strain, and her range of motion looks fantastic. She can do an absolutely great straight leg raise. She looks at that quad, and bam, that quad fires up, keeps it straight. She moves great. We put the EMG on her, and her activation compared to her non-injured side, she's got a 40. Or no, sorry. If you're listening, sorry, it wasn't 40%. 28% deficit compared to the non-involved side. But it looks great. You look at it and go, man, that looks really good. And I look at it and I'm like, we got to figure this out. So I put it on there, 28% deficit. She is not anywhere near she needs to be yet. Now, granted, she's way ahead of the game, which is great, but she's just not there. So that's something we're predominantly focusing on right now. So, Bo, great question. EMG, I would say EMG, using EMG technology is probably affected most of our athletes more on the rehab side. I would say we have been using it in the group setting. More on the rehab side. EMG seems to be kind of the most, what would you say, most, that's our most recent discovery, and integration has been that. So on the group side, I can tell you this, that we've been using a lot of video and measuring joint angles, those type of things lately, and it's been tremendous. It's helped us a lot. We just never been able to do it, and it just allows us, again, to give us quantifiable points with our athletes to make sure that they're making the gains that we want to see outside of like strength increases and those type of things. But we can easily measure broad jumps now within a moment's notice without having to measure and mark it and those type of things. Essentially, we walk out to the turf, they stand in one position. There's an app on my phone. I click where their feet are. They jump as far as they can. I click on their feet in a specific location that we've decided. And I go, okay, great. Hey, look, as of this week to last week, you're up 2 inches on your broad jump. We know the programs are working at that point. So great question, Bo. But yeah, I think that's EMG on the rehab side, and probably technology, video technology and measuring technology on the group fitness, I shouldn't say fitness, but group performance training setting. So, all right, let's see. That was it. 2 questions for this episode 25. We appreciate everybody who asks questions. We really enjoy answering them. Again, the goal of this podcast is predominantly just so we can get information out there that's good. We don't want bad information to circulate. We want to become a resource through this podcast, and the best way to do that is just to answer individual questions, and then hopefully those that are listening can use these questions to kind of make more informed decisions. That being said, if you do have questions, please ask them. We've always said we'll answer any and all questions we get. We kind of get waves of questions sometimes, but sometimes they kind of get pretty meager after a little while, and then they come back. So just ask away. We'll get those questions answered. We appreciate your time. We appreciate you hopping on here to listen to us. And if you have friends or anybody else you think would benefit from this, please share this podcast with them. Have them reach out. If you could also just review the podcast, it helps us become more visible to more people on Apple Podcasts and those type of things. So again, I appreciate your time. Appreciate you tuning in the podcast, and we'll catch you next time. Thanks.